This presentation is going to cover adrenergic agonists. Adrenergic agonists are some of our most important drugs because they can treat a variety of different symptoms and complaints that can be as small as nasal congestion to life-threatening conditions such as shock. And because they activate the same adrenergic receptors as our endogenous neurotransmitters, the therapeutic and adverse effects can easily be predicted. There's some selectivity. So if you really understand the physiological effects of the sympathetic nervous system stimulation, this is going to provide that foundation that you need to use the pathophysiology and the physiology to predict the effect and to treat your patient. Sometimes adrenergic agonists are called sympathomimetics because they're able to have a very similar activation as the sympathetic nervous system. They have the same receptors. We're going to approach this conversation by talking about generally the mechanism of action, an overview of the major adrenergic agonists that we have to use, the receptor subtype and the physiology, as well as knowing the drug properties of the sympathomimetics. There are four basic mechanisms in which drugs can activate the adrenergic receptors. They either fall into the direct or the indirect category. So it's either direct receptor binding, promotion of norepinephrine release, blocking norepinephrine reuptake, or inhibiting norepinephrine inactivation. Only one you see is through this direct mechanism, and this is what we are going to cover in this presentation, the ones with direct receptor binding. And direct interaction with receptors is the most common mechanism, which drugs activate peripheral adrenergic receptors. This direct acting receptor stimulants can produce effects by binding to an adrenergic receptor and then mimicking the action of the natural neurotransmitters. So it's going to mimic norepinephrine, epinephrine, and dopamine. By acting on terminals of sympathetic nerves to cause norepinephrine release, these drugs can bring about indirect activation of adrenergic receptors. And the drugs that act by this mechanism are going to be things like amphetamines and ephedrine. Now, ephedrine can also activate adrenergic receptors directly as well as indirectly. You can see here, again, the direct mechanism, the receptor activation through direct binding. Ephedrine, we have epinephrine, we also have dopamine and isoproterenol, which we've discussed earlier. Those drugs that work through indirect mechanisms are going to be amphetamine, ephedrine, promoting norepinephrine release. Inhibition of norepinephrine reuptake is going to be through cocaine and tricyclic antidepressants, and MAO inhibitors will inhibit MAO. There are two chemical classifications, catecholamines versus the non-catecholamines. The adrenergic agonists will fall into these classes, and they differ within respect to three different things: the availability for oral use, the duration of their action, and then their ability to act upon the CNS. And so a particular adrenergic agonist will fall into a different category based on these three prominent features. Thank goodness we're not back in organic chemistry. However, this does help you to understand how they differentiate from one another through the basic structure of the catecholamine. And mainly, it's because they contain a catechol group and an amine group, and that's why it's a catecholamine. And the group is simply a benzene ring with a hydroxyl group into the two adjacent carbons. Okay, that's really it structurally. In terms of the catecholamines, the non-catecholamines, their structure looks different. They do not carry the hydroxyl groups on the two adjacent carbons. You actually can see, in terms of the non-catecholamines, there is one hydroxyl group here, and then albuterol takes a different turn at that connection there. Okay. All of the catecholamines can't be given orally. They cannot cross the blood-brain barrier, or the BBB, and they have brief durations of actions. And the reason is that the MAO, the monoamine oxidase, and the COMT, which is the catechol O methyltransferase, are located in the liver and the intestinal wall. Well, both enzymes are very active and quickly will destroy the catecholamines that are administered by that PO route. Okay, so that's why we don't give it orally. It's going to become inactivated too soon before it can even reach the systemic circulation. And because of the rapid inactivation that's caused by the MAO, and the COMT, 3 catecholamines, norepinephrine, dopamine, and dobutamine, are effectively used by IV administration. We can also give other parenteral routes like subQ and intramuscular, but they're not going to yield the same effects in the blood level because of the rapid hepatic inactivation. So ideally, you are using norepinephrine, dopamine, and dobutamine in the form of continuous infusion. Catecholamines are polar molecules, so they can't cross the blood-brain barrier. And because they can't cross this barrier, catecholamines have minimal effect on the CNS. The non-catecholamines are a little bit different. They metabolize slower because they are not going to be affected by the COMT, and through the MAO, it's metabolized very slowly. So as a result, the half-lives of the non-catecholamines are much longer than that of the catecholamines. Also, they don't undergo rapid degradation by MAO or COMT. So these can be given orally, where remember the catecholamines can't. Lastly, they are less polarized, and so they are able to cross the blood-brain barrier. So those side effects will be more prominent in the non-catecholamines. And able to understand the action of individual adrenergic agonists, you also have to understand receptor specificity. Now, there's variability in the receptor specificity among the adrenergic agonists, and you can note those between albuterol, isoproterenol, and epinephrine. Albuterol is very selective. It works on the beta-2 receptors only. Isoproterenol, we remember, is less selective, acting on both beta-1 and beta-2 receptors. And epinephrine is going to be even less selective than that, and it's going to act on all 4 adrenergic receptor subtypes: alpha-1, alpha-2, beta-1, and beta-2. The receptor specificity of the major adrenergic agonists can be shown on subsequent table coming up, and you're going to see that on this table, the specificity is going to be presented to you so that you can see with the schematic how it works in terms of its pharmacology and what we should expect being a sympathomimetic drug. Now, the concept of receptor specificity isn't an absolute concept. The ability for a drug to selectively activate certain receptors depends on the dose. Now, at very low doses, selectivity is maximal. But as you increase the dose, the selectivity of the drug will decline. This is an important concept to remember. So for an example, when you give albuterol in low doses, the drug is highly selective for just the beta-2 adrenergic receptor. But when you increase it to very high doses, it will also activate the beta-1 receptor as well. This table is worth reviewing more than once and maybe even memorizing. You can see the difference between the catecholamines on the left and the non-catecholamines on the right, and the receptors that they activate. Now, below you see the receptors activated specifically to the drug. And here you note that, again, albuterol is highly selective, the most selective for beta 2. However, we see that isoproterenol can also work on beta 2 as well, but it works on beta 1 also. The butamine and dopamine only work on beta 1, so it's highly selective for beta 1. Dopamine can be highly selective for alpha 1, but also dopamine receptor. Epinephrine and ephedrine are the least selective, the most non-selective, because they can activate alpha 1 to beta 1 and 2 as well. Let's talk about the responses that we are expecting for alpha 1 receptors. We're going to talk about both the therapeutic responses and the adverse responses as well for each of the sympathomimetic drugs. Because adrenergic agonists activate more than one type of receptor, it sometimes can be confusing what the effects of these sympathomimetics can be without using specific drugs as an example. But our discussion is going to begin with alpha 1 receptors, and then we're going to move on to alpha 2 and so on and so forth, and get to all the way through the dopamine receptors as well. So in order to understand the effects of a specific adrenergic agent, we have to have two pieces of information. We need to know the identity of the receptor in which the drug acts upon, and then what effect can be produced by activating the receptor. So just like we have discussed with the muscarinics and the anticholinergics that we talked about in previous lecture. It's the same approach to understanding those neuropharmacologic agents. We know that activating the alpha 1 receptor, we should expect vasoconstriction, mydriasis, and the therapeutic applications for this is to achieve hemostasis. We can use it for nasal congestion. We can also use it as an adjunct for local anesthesia and with the elevation of blood pressure, because we can see that it's going to cause vasoconstriction and mydriasis. The adverse effects of activating an alpha 1 receptor, because of the vasoconstriction, we can cause hypertension. It can also cause necrosis and bradycardia as well. In terms of hypertension, the alpha 1 agonist produces that because of the widespread vasoconstriction, and severe hypertension is most likely going to occur when you are given a parenteral dose. So if you ever have to give an alpha 1 agonist intravenously, you must monitor the cardiac output, the rhythm, continuously. So check for things before you give it as well, and during, like blood pressure, peripheral pulses, urine output. All of those things need to be assessed frequently with alpha 1 agonists for the treatment, for the adverse effect of hypertension. Well, IV solutions of alpha 1 agonists can cause necrosis because it contains extravasates that can seep into the surrounding tissues. And this is going to result in necrosis of those tissues. It's blocking the blood flow to the affected areas that are secondary to the local vasoconstriction. And if this extravasation continues to occur, then that area can be infiltrated with an alpha 1 blocking agent to stop this from occurring. This will counteract the alpha 1 mediated vasoconstriction and then help minimize the injury. bradycardia can be caused by the alpha 1 agonist working on the reflex, slowing the heart. And this happens when the alpha 1 mediated vasoconstriction elevates the blood pressure. Well, what does that trigger to your body? It says, hey, I need to trigger the baroreceptor now. And that baroreceptor reflex is going to cause your heart rate to decline in reaction to that alpha 1 mediated vasoconstriction. In patients that don't have a lot of cardiac reserve, the decrease in cardiac output can compromise the tissue perfusion overall. With our alpha 2 receptors located in the periphery, the activation inhibits norepinephrine release. And there are several adrenergic agonists like epinephrine and norepinephrine that are capable of causing this A2 activation or alpha 2 activation. But the ability to activate the alpha 2 receptor in the periphery has little clinical significance because there's no therapeutic application related to triggering an alpha 2 receptor in the peripheral space. So really, if these receptors get activated, you're not going to have any significant reaction or adverse effect. However, if we contrast this to an alpha 2 receptor in the periphery, an alpha 2 receptor in the CNS has a very great clinical significance. If you activate a central alpha 2 receptor, it can produce two useful effects. We can reduce the sympathetic outflow of the heart and the blood vessels. We can also relieve severe pain. The central alpha 2 agonists that we use are going to affect the heart and the blood vessels. And we've talked about that in the previous presentation. So it's not the PNS that we're trying to activate here. It has little clinical significance. It's the CNS. The beta 1 receptors. It's important and clinically relevant to understand the difference between beta 1 and beta 2. We can use it therapeutically for heart failure. With heart failure, we're going to have a reduction in the force of contractility and also in result a decrease in cardiac output. And because the activation of beta 1 receptors in the heart has a positive inotropic effect, meaning that it's going to increase the force of contraction, drugs that activate the beta 1 receptors improve cardiac performance. We can also use it for shock, which is profound hypotension with reduced tissue perfusion. The primary goal of treating for shock is to maintain blood flow to the vital organs. Because we're able to increase heart rate and force contraction, the beta 1 stimulants can increase cardiac output, improving tissue perfusion that can be reduced during shock. We also use it for AV block. Atrioventricular block is a cardiac condition in which the impulses from the atria to the ventricle are either impeded or they're blocked completely. The result of this is that the ventricles are no longer going to be driven at an appropriate rate because it can't get that signal through from the atria. Because activation of cardiac beta 1 receptors enhances the impulse conduction through the AV node, beta 1 stimulants can help to overcome this AV block. But we do need to remember that this is not a long-term fix for AV block. It's a temporary form of treatment. Long term, if your heart can't push through that conduction from atria to the ventricle, you're going to need a pacemaker. We can also use it for cardiac arrest. By activating cardiac beta 1 receptors, these drugs have a role in initiating the contract that needs to occur during asystole or with PVR or pulseless ventricular rhythms. We have to note, though, that these drugs aren't the preferred treatment, but they can be used. During cardiac arrest, obviously CPR, cardiopulmonary resuscitation, external pacing, and defibrillation are going to be the first line treatments. When a beta 1 agonist is indicated, epinephrine is what's going to be administered through IV. So this should seem very familiar to you, working with CPR, MOC codes, or ACLS protocol. Now we're going to move on to talking about the adverse effects of beta 1 activation. It results from activating the beta 1 receptors in the heart, and then we're only going to be talking about the ones in the heart. Activating the renal beta 1 receptors isn't associated with these effects. Okay, so just the heart. The adverse effect of beta 1 activation can cause an overstimulation of beta 2 receptors, which will then produce tachycardia and dysrhythmias. With angina pectoris, drugs that can activate the beta 1 receptors can precipitate an attack of chest pain or angina pectoris, which is a condition in where your patient is going to feel substernal pain around that precordium area. And this pain can occur when there is a decrease in cardiac oxygen. And this oxygen supply is insufficient to meeting the demands of your body, or that cardiac oxygen need throughout the body. And the most common cause of angina is going to be some type of coronary event like atherosclerosis, which is that accumulation of lipids and cholesterol in your coronary arteries. Because beta 1 agonists will increase cardiac oxygen demand through the mechanism of increased heart rate and contractility, patients with compromised coronary circulation are going to be at risk for an anginal attack. With our beta 2 receptors, these are going to be the ones that are limited to the lungs and the uterus. Okay, so we're just talking about those. With asthma, knowing this is a chronic condition of inflammation and bronchoconstriction, if we use this during a severe attack, we can help bring back the airflow that's necessary. Because the drugs activate beta 2 receptors in the lung, we are going to see bronchodilation, helping the patient to increase that airflow and prevent an asthma attack, or to help reduce the exacerbation of that attack. Okay, so it's activating the beta 2 receptors in the lung, promoting bronchodilation. For asthma, adrenergic agonists that are selective for beta 2 receptors, like albuterol, are going to be preferred over less selective things like isoproterenol, which you know can work on both the beta 1 and the beta 2. So we're looking for something very selective here. Most of the beta 2 agonists treat asthma through inhalation. And this route is going to be the most desirable because it's going to minimize adverse systemic effects throughout the body. Though it doesn't guarantee that inhalation is going to be safe completely, because you still need to look for systemic toxicity that can result from overdosing on inhaled sympathomimetics. And this is why you need to warn your patients on following the directions of the inhaler that's prescribed. Activation of the beta 2 receptors in the uterus can relax uterine smooth muscles. And using drugs that work on this beta 2 receptor can delay premature labor and thus premature delivery. Hyperglycemia. This is the most important adverse effect in response to beta 2 activation. Remembering that our drug that we talked about earlier, isoproterenol, works on both beta 1 and beta 2, we know that in addition to causing bronchodilation, we can also cause hyperglycemia. The mechanism of activation of the beta 2 receptors in the liver and the skeletal muscles will promote this breakdown of collagen into glucose. So beta 2 agonists will cause hyperglycemia only in patients with diabetes. If your patient has a normal pancreatic function, then your insulin is going to be released in response to this, right? Because your body works well, you don't have diabetes or insulin resistance. So when there's a spike of hyperglycemia, then your body knows to produce insulin in reaction to that. But when you have diabetes and you have the breakdown of glycogen into glucose, then you won't have enough insulin in your body, or no insulin at all, depending on what type of diabetes you have, to combat this hyperglycemia. If hyperglycemia develops in patients with diabetes, then you need to now prescribe medication for glucose control, and you might need to adjust it. So it's up to you to decide, does this patient really need this medication, or is there perhaps a more selective medication to use? The most common side effect of a beta 2 agonist is tremor, and this is often why you will see it with patients that take albuterol. And it's because of the activation of the beta 2 receptors in the skeletal muscle. It's enhancing the contraction. This effect can be so confounding for patients with diabetes because tremor is also a common symptom of hypoglycemia, and it can confuse them on whether they have hyperglycemia or hypoglycemia. When you see tremors due to beta 2 activation, it's going to be accompanied by hyperglycemia. This is how they're going to know. So the only way to check is check their blood sugar. Fortunately, this tremor is going to generally fade over time in both our patients with diabetes and those that are taking it as an inhaled bronchodilator for asthma or COPD. Activation of peripheral dopamine receptors will cause dilation of the renal vasculature. Because of this, if we use it for shock, it's going to help dilate the renal blood vessels, improving perfusion in the kidneys and reducing the risk for renal failure. Dopamine is the only drug that's available that can activate these dopamine receptors. And when it's given to treat shock, it also is going to enhance cardiac performance because it activates the beta 1 receptors in the heart as well. Here again, just quickly, is that list of adrenergic agonists that we've been talking about: epinephrine, norepinephrine, isoproterenol, dopamine, dobutamine, phenylephrine, albuterol, and ephedrine. Take a moment to see if you can perhaps recall through memory which receptors are selective and which are not for each of these drugs. This table shows the pharmacokinetics of each of these adrenergic agonists, and these are all IV administration except where it says that it is not. So you see here that most of them will have an immediate onset of action, but even when it's not immediate, it's pretty quick. With the exception of albuterol, that takes sometimes up to 10 to 30 minutes. Everything else is working in about immediate to 2 minutes. You can also see the metabolism of MAO and COMT, or only if it's COMT, or hepatic only. Most of these are eliminated only by urine, but albuterol is also eliminated through the feces as well. So take a look at this chart in terms of half-life, duration, metabolism, onset of action, and elimination. The specificity of epinephrine is for alpha-1, alpha-2, beta-1, and beta-2, and its chemical classification falls under catecholamine. Sometimes we refer to this as adrenaline, and it's among the first adrenergic agonists that were employed clinically. And because of this, we consider it to be a prototype of the sympathomimetic type drugs. It's going to be discussed in detail compared to the other drugs because it is our prototype. And epinephrine can activate, again, all four of these subtypes of the adrenergic receptors. Therefore, it's going to have a very broad spectrum benefit of sympathomimetic effects. So what are these effects? Because it causes alpha-1 mediated vasoconstriction, epinephrine can be used to delay the absorption of local anesthetics and control superficial bleeding and elevate your patient's blood pressure. Because it activates beta-1 receptors, epinephrine can be used to overcome AV block, restore cardiac function in patients in cardiac arrest, and those that are experiencing ventricular fibrillation, pulseless VTAC, or pulseless electrical activity, PEA, or even asystole. It also activates beta 2 receptors in the lung, promoting bronchodilation, so it can be used with patients with asthma, but again, it's not the drug of choice. We'll go for that beta 2 highly selective albuterol. Because it activates a combination of alpha and beta receptors, it's a treatment of choice for anaphylactic shock. In terms of pharmacokinetics, it can be administered both topically or by injection. You do not give epinephrine orally because epinephrine and the other catecholamines, remember, they undergo that destruction of MAO or MAO and the COMT before reaching the systemic circulation. So essentially, you won't get any action. After a sub-Q injection, absorption is going to be slow because epinephrine-induced local vasoconstriction is occurring. Absorption is more rapid after an IM injection, but it's going to be the best and most immediate with an IV administration. As a short half-life because of the enzymatic inactivation and uptake into the adrenergic nerves, and these enzymes will inactivate epinephrine and other catecholamines. Remember the enzymes MAO and COMT, MAO and COMT. Because it activates the 4 major adrenergic receptor subtypes, we're also going to have multiple adverse effects. It can cause hypertensive crisis. The vasoconstriction that's secondary to the excessive alpha-1 activation can dramatically increase your patient's blood pressure. It can cause cerebral hemorrhage to occur because of the potential for severe hypertension. You have to understand that patients receiving parenteral epinephrine have to be monitored very closely, cardiovascular-wise, and also you're going to get a frequent assessment of all their vital signs. It can also cause dysrhythmias because of the excessive activation of beta 1 receptors in the heart. They're very sensitive to catecholamines. Hyperthyroid patients are at high risk for epinephrine-induced dysrhythmias. By activating the beta 1 receptor in the heart, epinephrine can cause cardiac work and oxygen demand to increase. And if it's significant enough, it can cause an anginal attack, causing chest pain. And it's usually those patients that already have coronary atherosclerosis. If an IV solution containing epinephrine extravasates your patient's IV, it can cause localized vasoconstriction resulting in tissue necrosis. And because of this possibility, that IV site needs to be monitored very, very closely if you're giving epinephrine. Again, if it happens, it can be minimized by a local injection of an alpha adrenergic antagonist called phentolamine. Remembering again what it does with hyperglycemia. So in patients with diabetes, epinephrine can cause hyperglycemia by promoting the breakdown of glycogen that's secondary to the activation of the beta 2 receptors in the liver and the skeletal muscle. If this happens, you have to either decide, do you need to stop the medication or adjust the medication that's going to manage their blood sugar. So there are many drug interactions with epinephrine. With the monoamine oxidase inhibitors, as the name implies, the MAO inhibitors are going to suppress the activity of the MAO or the MAO. And these drugs are usually going to treat depression. Because the MAO is one of the enzymes that inactivates epinephrine and other catecholamines, when we use a medication that inhibits MAO, we're going to prolong and intensify the reaction of epinephrine. So in most situations, if you are giving a patient a MAO inhibitor, they should not also receive epinephrine. With tricyclic antidepressants or TCAs, they're going to block the uptake of catecholamines into the adrenergic neurons. Because of this neuronal uptake, the actions of norepinephrine and other catecholamines are going to be terminated. So if we block the uptake, this can actually intensify and prolong the epinephrine effects. So for those patients taking tricyclic antidepressants, they're going to require a lower dose whenever you need to use epinephrine. In terms of general anesthesia, There are several inhalation anesthetics that will cause myocardium hypersensitivity to the activation of beta 1 agonists. So when your heart is in a hypersensitive state, that exposure to epinephrine and another beta 1 agonist can cause tachydysrhythmias. If you take epinephrine with alpha adrenergic blocking agents, these drugs that block the alpha adrenergic receptors can prevent the alpha adrenergic receptor from activating epinephrine. So alpha blockers can be used to treat the toxicity that's caused by excessive epinephrine-induced alpha activation. So if you have a patient that had been given epinephrine and they have the side effect of hypertension and vasoconstriction, you can actually reduce this by giving them an alpha adrenergic blocking agent. Drugs that block beta adrenergic receptors can prevent beta adrenergic receptor activation by epinephrine as well. And so beta blocking agents like metoprolol and other beta blockers will reduce the adverse effects that are caused by epinephrine on other beta 1 agonists. So if you're giving them a epinephrine that's causing dysrhythmias or anginal pain, if you give a beta blocking agent, you're actually going to reduce those adverse effects. With norepinephrine, we have specificity to alpha 1 and alpha 2, but only beta 1. Again, this is also a catecholamine. We're still talking about catecholamines. Norepinephrine is similar to epinephrine, but in regards to receptor specificity, norepinephrine differs because only in norepinephrine do we have a lack of activation of the beta 2 receptor. Remember, epinephrine was non-selective. It went over alpha 1, alpha 2, beta 1, and beta 2. But with norepinephrine, we don't activate beta 2 receptors. So norepinephrine can elicit all of the responses that epinephrine can, except for the beta 2 mediated responses. Because it's a catecholamine, it's also going to be subjected to rapid inactivation by MAO and COMT, and it can't be given orally. The adverse effects are going to be pretty similar to epinephrine: the tachydysrhythmias, the anginal pain, hypertension, and the local necrosis of extravasation. But differently than epinephrine, it's not going to promote hyperglycemia because that's a response that's mediated by the beta 2 receptor. Just like epinephrine, though, the responses to norepinephrine can be modified by taking MAO inhibitors, tricyclic antidepressants, general anesthetics, and adrenergic blocking agents as well. Okay, so the only difference here is the beta 2 that you're thinking about. But despite the similarity to epinephrine, norepinephrine has limited clinical applications. It's only recognized and only really indicated for hypotensive states and cardiac arrest. Isoproterenol is only selective and has a specificity for beta 1 and beta 2. It's also catecholamine, and it differs significantly from norepinephrine and epinephrine because it only is going to act on the beta adrenergic receptors. Isoproterenol is the first beta selective agent that we use clinically. By activating beta 1 receptors in the heart, isoproterenol can benefit patients with cardiovascular disease. Specifically, it can be used to manage AV block. We talked about that, where the atrium cannot fire to the ventricles. And this will improve outcomes in cardiac arrest and increase cardiac output during shock as well. But because isoproterenol doesn't activate alpha adrenergic receptors, it produces fewer adverse effects than norepinephrine and epinephrine. This is why we like it for that reason. The major undesired responses that are caused by activating beta 1 receptors in the heart, though, are tachydysrhythmias and anginal pain. In patients with diabetes, isoproterenol shouldn't be used because it's going to cause hyperglycemia. It's promoting that beta 2 mediated genolysis that turns into glucose. The major drug interaction for isoproterenol is identical to epinephrine. You're going to also get the effects of the MAO inhibitors and the tricyclic antidepressants as well. And reduced, it's going to be reduced by the beta adrenergic blocking agents also. So just like epinephrine, it can cause dysrhythmias in patients that are receiving anesthesia by inhalation. Now, dopamine receptors have specificity on the dopamine receptor, beta 1, but at very high doses, you can actually activate alpha 1. It's also catecholamine, and it's dose dependent, right? So high doses alpha 1, lower doses beta 1 and dopamine. When you administer in low therapeutic doses, we're only going to activate the dopamine receptor and only the dopamine receptor. In moderate doses, you get the beta 1 receptor. And then in very high doses, it's going to activate the alpha 1 receptor as well as the beta 1 and the dopamine receptors. So the higher the dose, the more it loses its selectivity, and it will be selective for all three. The major indication for using dopamine is for shock, and the benefit is really through the effects of the heart and the renal blood vessels. If you activate beta 1 receptors in the heart, then dopamine can increase that cardiac output, improving your patient's tissue perfusion. And then you activate the dopamine receptors in the kidney, then we can dilate those renal blood vessels, which will improve the perfusion of the kidneys. But studies show that it's not effective in preventing acute renal failure. At very high doses that activate alpha 1 receptors, vasoconstriction can actually decrease renal perfusion, and it's going to override the effects of the dopamine activation. You have to monitor urine output when you are treating someone with dopamine for this reason. Dopamine can also be used for heart failure. We know that with heart failure, we get a reduced perfusion to the tissues due to the reduced cardiac output. And dopamine can actually alleviate the symptoms by activating the beta 1 receptors in the heart, causing an increase in contractility and therefore increasing cardiac output. The most common side effects or adverse effects of dopamine are tachycardia, dysrhythmias, and anginal pain, and this is through the activation of beta 1 receptors in the heart. Dopamine is contraindicated for any patient that already has an underlying tachydysrhythmia or ventricular fibrillation. Because of the high concentrations of dopamine causing activation on the alpha 1 receptor, extravasation may result in necrosis from localized vasoconstriction if you're giving high doses of dopamine. That tissue injury can be minimized again by using a alpha adrenergic antagonist to help with the reaction of extravasation. It's going to minimize that local infiltration. We have dobutamine, which is specific for beta 1. It's a catecholamine as well, and in therapeutic doses, it's going to have a very selective activation of beta 1 adrenergic receptors. And it's the only indication. Dobutamine is only used for heart failure, and the major adverse effect is tachycardia. And if you're going to give dobutamine, make sure your patient is being monitored by an electrocardiogram and blood pressure. It does have interactions as well. Dobutamine works on the heart and blood vessels to intensify the cardiac output, but also when you use a MAO inhibitor, it's going to increase that effect. In patients that are receiving a MAO inhibitor, dobutamine dosages have to be reduced by so much as 90%, so by almost everything. Concurrent use of a TCA or tricyclic antidepressant can also cause a moderate increase in those cardiovascular effects as well. And there are some general anesthetics that will sensitize the myocardium to stimulation by dobutamine, and so this will also increase the risk for dysrhythmia. Phenylephrine is specific to alpha-1, but now we're moving on to the non-catecholamines. And phenylephrine is selective only to alpha-1 agonists, and the drug can be administered locally to reduce nasal congestion. And we can also give it parenterally, though, to help to bring up a person's blood pressure. Additionally, we have eye drops that can be used to dilate the pupil, and it can be co-administered with local anesthetics to help delay that anesthetic absorption. Albuterol, we know, is a beta-2. It's a non-catecholamine. We know it under their trade names as Proventil, Venolin. There's quite a bit, but is the drug choice of treatment for asthma, and it's helping to reduce airway resistance because it's causing that beta-2 mediated bronchodilation. Very selective for beta-2 receptors, and it produces a much less of an activation of cardiac beta-1 receptors than does the drug isoproterenol. And so this is why beta-2 selectivity that we have in albuterol is much better than the isoproterenol. If we give it in large doses, though, it will start to activate beta-1 receptors as well as beta-2 receptors. So warn your patient not to overdo their inhalation of albuterol. If they do, it can overstimulate their cardiac system and cause undesired cardiac side effects. Make sure that you are giving the minimal dose necessary, but as an adverse effects, tremors are going to be the most common, as well as tachycardia, because it's activating the beta-1 receptor in the heart at very, very high doses. Ephedrine is specific for alpha-1, 2, beta-1, and beta-2, and it is another one of the non-catecholamine drugs. It has a mixed acting activation of adrenergic receptors by both direct and indirect mechanisms. Directly, it's going to bind to the drug or bind the drug to alpha and beta receptors, and indirectly, it's releasing norepinephrine first from adrenergic neurons. But because we have more selective adrenergic agonists, we don't really have a wide use for ephedrine. When we promote beta-2 mediated bronchodilation, ephedrine can benefit patients with asthma, but again, albuterol is that first line. By activating a combination of alpha and beta receptors, it can also improve hemodynamic status in our patients with shock, and it can be used to manage anesthesia-induced hypotension as well. Now, because this drug activates the same receptors as epinephrine, they're going to share the same adverse effects like hypertension, dysrhythmias, anginal pain, hyperglycemia. It doesn't act the same way on the blood-brain barrier, however. Ephedrine can cross the blood-brain barrier and it can act on the CNS, so it can cause insomnia in your patients. If you want a little bit more detail or a review as we prep and get ready for the final, other chapters in our text that talked about the alpha-1 and 2 and the beta-1 and beta-2 agonists can be found in these respective pages. Just remember, when you are prescribing these drugs, that you are identifying first your high-risk patients. In patients that already have an underlying cardiac dysrhythmias or some type of organic heart disease, hypertension, or hyperthyroidism, take into consideration those diseases before prescribing. You are being extremely cautious about angina pectoris, diabetes, and patients receiving MAO inhibitors, tricyclic antidepressants or TCAs, and general anesthetics as well.